Good morning and welcome to the Femasys KOL event on FemBloc, a first of its kind medical solution for permanent birth control and an important option for women post overturn of Roe v. Wade. At this time, all attendees are in listen only mode. A question and answer session will follow the formal presentations. If you'd like to submit a question, you may do so by using the Q&A text box at the bottom of the webcast player or by emailing your questions to questions@lifesciadvisors.com. As a reminder, this call is being recorded and a replay will be made available on the Femasys website following the conclusion of the event. I'd now like to turn the call over to your host, Kathy Lee-Sepsick, Founder, President, and Chief Executive Officer of Femasys. Please go ahead, Kathy.
Thank you, Tara. So this is a slide with our agenda for this event today, and you can see that it's chock full of great information related to our FemBloc program, as well as an impact potentially to the program, given the Dobbs-Jackson decision most recently. I am so honored to have as our key opinion leader for this event, Dr. Paul Blumenthal is joining me. He has a very long and distinguished career, and it spans nearly 40 years. He's been a prominent member of the Stanford School of Medicine's team, and his bio is detailed here. It's quite lengthy, so I'll just hit a few of the high points. Dr. Blumenthal has focused his career on family planning, which is included reproductive health education and services. He's been a driving force on a number of different global initiatives, of which are listed here, just a small sampling, and he has authored and contributed to hundreds of publications, been a very much driving force in this area. So I'm very honored to share the time here today with him. So I'm going to begin. I will be noting some forward-looking statements as part of this presentation. So who are we? I am the founder of Femasys, and I started the company with a sole mission in mind, was to change women's healthcare and to do so with very novel products and to enhance the in-office opportunities for procedures, et cetera, for OB-GYNs and patients alike. I did take the company public a little over a year ago. So it's just some financial information listed on the slide. We have a number of products. One of the things I set out to do was not be a single product initiative. I wanted to have platform technologies where we were able to impact a number of different key areas within reproductive health. Today, as part of this key opinion leader event, we will be focusing on the FemBloc product, which is our permanent birth control solution. And I'll give quite a bit more detail on that product. All of the products that were listed on that previous slide are protected by a global intellectual property portfolio. We have over 130 patents that have been issued globally. We have over 40 pending. We're continuing to add to our portfolio. Quite essential that and quite an effort for us from the early days to make sure that these technologies are protected. So looking more closely at what we're working on, as I mentioned, we wanted to take our platform and leverage it. We wanted to focus on the office primarily and look at minimally invasive solutions for that targeted point of location. So our platforms share and leverage existing skill sets. Specifically for the FemBloc product, we have developed an approach that allows for an OBGYN to deliver the solution much like they would deliver an intrauterine device or an IUD or intrauterine catheters. These are skill sets that are quite commonly known and taught during residency programs, et cetera. So we leverage that. And in the case of FemBloc, we deliver dual catheter technology where we're isolating the opening of the fallopian tubes. In our other platform technologies, we do a single approach, but it's the same essential skill set. We are approximating the opening of the fallopian tubes, and in doing it in this approach, we've eliminated the need for anesthesia, incisions, special skill set, capital equipment, and we most importantly do not cannulate or thread into that small fallopian tube. And this allows us to deliver a number of different things to the tube. Specifically for FemBloc, we are delivering our developed biopolymer, and I'll speak to that in more detail in a second. We also have a platform of products that utilize the delivery of a contrast agent. We basically make bubbles. And when we do that, we're able to visualize and evaluate the fallopian tubes. And this is essential for a lot of the products that we're working on. Specifically for FemBloc, we're looking to engage this type of technology to confirm procedure success. And in doing this and enabling ultrasound, we've moved this important test from a referral to a radiologist. We've eliminated exposure to ionizing radiation, the necessity of utilizing X-ray dye. Those are all important aspects as we attempt to bring forward what we believe will be an ideal solution for women. So more detail on FemBloc. We believe this will be the first and only non-surgical approach. We're not aware of anyone really actively developing in this area. And as we know, there is one current option for women available globally, which is surgical tubal sterilization. And we are looking to be a non-surgical approach and engage again in the office. So how many women does this affect? This number looks to be perhaps on the rise. We see 800,000 women choosing surgical tubal ligation as a form of birth control every year. And this is a very well-reported area, actually. So these are not management's numbers, but there are over 13 million women that are categorized today as no longer intending to have children. So this leaves over 12 million women using a non-permanent birth control method to satisfy this need. We see significant advantages over surgery. Clearly, non-surgical, we're eliminating that anesthesia risk. We're eliminating incisions, longer recovery time. We do not leave an implant behind. We do not rely on hormones. We do see this as a one-time treatment as well as surgical tubal ligation, but we are also engaging in a confirmatory test, which I'll mention in a slide or two, just to confirm procedure success. We believe that in developing a technology like this that is non-surgical, that there is true worldwide applicability. More recent information related to surgical tubal sterilization is that the effectiveness rates may not be as good as we once thought. And this is more, this literature has just been published this year, where they showed a 6% failure rate for laparoscopic sterilization and a 5% failure rate for hysteroscopic sterilization. This was the eSure product. This product was removed from the market in 2018 due to safety concerns related to their device. They left an implant or a coil behind in patients, and it lent itself to a number of safety concerns that we absolutely have not seen, nor do we expect with FemBloc, given our mechanism of action. So this is the current landscape. Women are using long-term reversible methods like an IUD. So that's listed there. That is not a permanent method, requires a number of these to span perhaps those reproductive years. And the market share leader is hormonally based, which carries its own safety risks. So looking at FemBloc a little bit more closely, how does it work? How do we design it? Again, we deliver similar to other intrauterine devices. So that part of the procedure is minutes in length, where that delivery component is delivered and then removed. We place or deliver strategically to the fallopian tubes. So our biopolymer, which is a tissue adhesive based product, delivers as a liquid and then forms into a solid once it reaches the tissue and comes in contact with the fluid there. So we anticipate, and we have seen the biopolymer solidify at the opening of the tubes and then go into the fallopian tubes. We anticipate full degradation of the biopolymer within 3 months. That certainly happens more short term for the biopolymer that's in contact with the lining of the uterine cavity. Ultimately, we see it fully degrading from the fallopian tubes as well. In the process of degrading, it is initiating a wound healing response. And our intent was to leave a small amount of scar tissue behind in the patient's fallopian tubes as her long-term occlusion or blockage. The reason we set out to do it this way is that we did not leave an implant behind. So this is a non-implant approach, which eliminates the fear of effectiveness rates being compromised down the line should it not work the way originally intended, or safety concerns as we've seen with other predecessor products. We also felt that this was an acceptable approach because women that are dealing with infertility issues often have blocked tubes that are scarred, which is why they cannot get pregnant. And most often they are asymptomatic or have no idea that that's the case. So that is the effect that we're striving for. And we confirm that procedure success with our own technology, utilizing the bubbles and the contrast that we create. We do have a product on the market for a number of years that's demonstrated safety to deliver those bubbles to evaluate the fallopian tubes, called FemBloc. So where are we in the program to bring this to market? When you have a safety concern that arises in the market with a predecessor product, it necessitates a good amount of safety data be accumulated. And that's in fact what we exactly did. We had a large safety data set. We are following patients for 5 years. It's 183 patients that were exposed to the delivery mechanism as well as the biopolymer. And we collected a significant amount of data, and patients were found to tolerate the procedure very well. Physicians found it extremely easy to perform and much easier than surgery. So the stage that we're at currently is a very small study where we are looking specifically at the confirmatory test. Is the ultrasound test going to be robust, accurate enough in comparison to that radiology test to move forward in the program? So we anticipate having enrollment completed third quarter of this year for this part of the program. We then will move into our last stage, which will require another IDE. This will be a pivotal trial where we'll demonstrate effectiveness and add to the safety data set that we currently have amassed. So looking at the safety data to date that we've accumulated, we've seen no serious adverse events in those 183 subjects. And the majority of the events that were reported occurred within 7 days of the procedure. So this very much indicates that the adverse events were related to the procedure itself. The events were mild, mostly in nature. And so what were they? They fell into primarily 2 categories. We saw about 40% of our patients that had some bleeding and spotting, and about 40% of our patients that had some pain and cramping. These were all considered anticipated events that we would see, that physicians see when they do other intrauterine procedures like IUDs. So very anticipated adverse event profile. We also collected pain scores for our patients. How did they tolerate the procedure? All of our patients are awake. There's no anesthesia. And this was on a visual analog scale from 0 to 10, where 10 was the worst pain, 0 being no pain. The average was 4.3 for that FemBloc treatment, that delivery of biopolymer, and 3 on average for the confirmatory test using ultrasound. So well tolerated. So this market opportunity, as we look at it as a whole, we do think that the landscape is going to change. We do see demand increasing potentially for tubal ligation surgery. But if we look at the numbers that have been presented, about 800,000 women, and then include their partners that are getting vasectomies, also we anticipate that being on the rise. That's about 1.3 million couples annually going through a permanent procedure. This equates to about a $2 billion near-term market opportunity should we be able to convert those patients to a non-surgical approach. If we look at market expansion opportunities, this exceeds 20 billion. This includes the over 12 million women that are actually done having their kids or don't want to have any children, that are using some form of non-permanent option that may elect a form of birth control that's permanent if it's delivered in an office environment. So that is the current landscape. Looking at the economics, we do anticipate that the Affordable Care Act will be around when FemBloc clears the regulatory hurdles, what that means is that we anticipate the FemBloc treatment procedure to be at no cost for the patient. But what does it mean for the healthcare system and what does it mean for the physician? We see a dramatic overall cost reduction for the overall healthcare system. On average, surgical tubal ligation costs about $6,000, and that's attributed to the facility fees, the cost of anesthesia, all the pre-op, post-op care, and physicians, reimbursement is quite small in that overall. When we look at bringing an in-office solution, we are looking to be less than half the cost of a tubal ligation procedure, part of it being attributed to the cost of the system itself, and then the remainder going to the practice and the physician. We see through our clinical work that the procedure is very easy to perform in the office. The logistics go hand in hand with what's already performed, i.e., other birth control methods, and the patient walks out the door and resumes normal activity. As far as the reimbursement pathway, we are seeing 3 potentially reimbursable events. We've actually changed this slide recently because slide 1, we do anticipate may be done through telemedicine, and that will stick around in the future and be a much more effective way of speaking to patients and counseling them regarding their choice to entertain something permanent. But for FemBloc, the treatment part, the confirmatory test, that will always be done in the office with the physicians having to deploy that technology. And again, we see no cost to the patient and that we will engage in a satisfactory reimbursement coverage for the physician. We do have a category 3 code already approved as part of the overall strategy to seek widespread reimbursement for this technology when it becomes available. We also have a category 3 code approved for that ultrasound confirmatory test as that 3rd step. So investment highlights for the company. Our mission was set out to change women's health, look at disruptive technology, look at very significantly underserved areas. And we find ourselves, this is 18 years later for me, since I founded the company, that these areas still have no real competitive threat. They still lay there dormant and begging for change and begging for more options for women. We see clear reimbursement paths. We see an overall benefit for the healthcare system. We see a benefit for their physicians to be able to deploy more technologies to their patients in a safe manner in their office. And we're set out to bring forward not just FemBloc, but a number of products to the patient's primary care doctor, which is their OB-GYN. And we as a company have, and I'm very proud of this, is we want to be commercial ready. These are very big market initiatives. So we've spent years developing our manufacturing, honing in our abilities there, ensuring that we'll be able to scale appropriately, transfer the technology when the time comes. And we've protected ourselves, and we have now are now a public entity where we see better access to capital and hopefully support from the investment community. So with that, I'd like to turn it over to Dr. Paul Blumenthal.
Thank you, Kathy. And good morning, everybody. Kathy, thank you for that very kind introduction. My mother would have been very proud. I do want to share with you some insights and some observations that I've personally had with the FemBloc system and with FemView, which is the confirmatory component as well. And perhaps just starting with the bottom line here, as a clinician who has performed these procedures, and I'm sure there'll be a slide about this later, these are easy to do, and they can be done in the office with the kind of equipment that almost every gynecologist has in their office today. And beyond that, even no real special training beyond what one gets in residency is really required for these procedures these days. So let's, having said that, starting with the bottom line at the top, let's go on to the next slide. And just to share with you this historical context, as many of you know, historically, sterilization was the most common, the most popular form of contraception in the United States. If you took all comers and looked at who was using what between men and women together, and by the way, in a recession, the lines for vasectomy formed to the left. And that's because vasectomy is an office procedure, just like FemBloc can be. And so historically, it has been a very popular procedure. Over the years, though, access has sort of decreased because female sterilization procedures are done in the operating room, and it's very difficult to access operating room time. The operating room is an expensive place to do business, and especially since historically so many women would access contraception of this type, permanent contraception, immediately postpartum. As I'll show you, that became even more difficult in the current labor and delivery environment. Next, please. So as Kathy might have mentioned, this is enormous. This is an enormous market. We have 800,000 women who would choose permanent contraception, but others are using temporary methods, and survey after survey shows us that they're not always happy with the options currently available to them. And many are using the method they use because the method they really wanted either wasn't available or wasn't really acceptable to them. And if you just look at the 4 million or so women who are now using what we call long-acting reversible contraceptive, LARCs, such as IUDs or implants, you can see that now represents approximately 35% of the clinical market. And that shows us people are voting with their feet in the sense of wanting to establish or get a method that's a longer term. Now, as Kathy mentioned, LARCs are not permanent, but they do require resupply, removal, reinsertion, visits like that. They can be expensive depending on kind of insurance coverage you have. And the fact that LARCs are now 35% of the market also speaks to the interest in the public for much longer term methods. Maybe 10, 15 years ago, LARCs were only about 3% of the market, and the IUD had a lot of baggage that it brought to the table. So the interest in LARCs really speaks to the interest of women and couples, as a matter of fact, in looking at much longer term solutions to their contraceptive needs. Next, please. And women are requesting sterilization. And those of you who listen to NPR or CNN might have heard some of these reports that, especially after the recent Roe versus Wade Supreme Court decision, what's now often called Dobbs, because it was Dobbs versus a clinic in Mississippi, women are, the line is forming to the left or to the right for sterilization procedures because women do not want to make mistakes. They cannot afford to make mistakes in something like 30 states now. So whether they're searching for information, whether they're actually making appointments, there's definitely been a sudden rise in increase in interest about female sterilization. This is going to increase for the foreseeable future, and as most of you are sure aware, this Supreme Court decision is going to have very long-lasting effects. I often compare what the Supreme Court just did with what happened during Prohibition, where it took about 15 years to overturn Prohibition. I think that's the kind of ghost of Christmas future, if you will, that we're dealing with here. And as women search for possibilities of sterilization, I think FemBloc is in a great position to offer them something that's more accessible and easier to perform on both the patient side, because it's just much less involved, but also on the clinician side, because for us, going to the operating room, making the scheduling appointments, etc., is a major undertaking in some cases where we don't control the operating room, but we do control our offices. Next, please. And this goes to the point of data have showed us that 50% of women who request a sterilization, they never get it. They leave the hospital after giving birth, without the sterilization that they had wanted. And there are lots of reasons for this, but some of the most important ones are shown here. The fact is that especially labor and delivery units where women stay for maybe 24 hours after birth, they're not in the business of providing contraception. They're in the business of delivering babies. And so trying to go to an operating room on the labor and delivery suite where we would ordinarily do a postpartum sterilization procedure is just not necessarily so easy. These sterilization procedures have low priority to the constant chaos that's going on labor and delivery every day. And operating rooms are, as I mentioned before, they're expensive places to do business and in short supply, so that the office situation, which there are many more offices than there are operating rooms, is a much better place for us to consider these kinds of things. No one does an IUD, or very, very rarely does an IUD insertion in the operating room. And as Kathy may have mentioned, a FemBloc procedure is really not that dissimilar to something as simple as an IUD insertion. We know that 40 to 75% of women plan to use an IUD postpartum, but often for the same reason, we are not able to insert those IUDs immediately after birth. And of those women who wanted an IUD, something like I said here, 40 to 75% never get that IUD, which commonly results in an unintended pregnancy in the first 18 months after birth, which is really bad timing because birth interval spacing is critical to maternal health as well as to the health of subsequent infants. So we really feel, and this is why I've been involved in the project myself, these office-based procedures like FemBloc can increase both the adoption of sterilization procedures and access to them. Next, please. So again, as Kathy also mentioned, but this has been pretty clear for a number of years, permanent birth control options are not always effective as we once thought. And that has a lot to do with what happens in the marketplace after a procedure goes off study and into the general market. You can see here the statistics from a very recent paper, which showed that a laparoscopic sterilization, which is now the only type of sterilization effectively available other than what we call mini lap, or small open incisions, which use essentially the same techniques as laparoscopic procedure, but it's just a small incision. They're just not as effective as we might have assumed. And these new data actually reinforce data from a famous study called CREST, which was the Collaborative Review of Sterilization, which was undertaken actually by the CDC a number of years ago. And it showed pretty much the same thing, that the procedures over time are just not as effective as we might have thought. And the reasons for that there are multiple reasons for this, but a lot of times it has to do with the fact that we don't routinely or cannot really routinely check for the success of a laparoscopic sterilization procedure. You may or may not be aware of the problems with Essure and the reason it was taken off the market. And that had a lot to do, though, with how the Essure implant, the device itself, was placed, a problem that we don't have with FemBloc, and also the fact that there is often a learning curve to these procedures. And in many programs, residents were doing the procedures, especially in the CREST study, and residents are not as experienced as gynecologists in their office. So I think there's a number of reasons why these studies, these recent data, also ring true, but it's something that we have to bear in mind and looking for newer, innovative, more, and potentially more effective permanent methods. Next, please. So again, unintended pregnancy rates, something we really try and avoid with every ounce of our clinical means. They're unacceptably high. They've been steady for about 50% in the United States for over 20 years. And one of the reasons is that women need to access reliable contraceptive methods. and methods that they can appreciate both the technique, they can access the technique, and as I showed you before, they want longer acting reversible contraceptives, or as we've also showed you, permanent methods. There's just no reason to keep changing IUDs or implants if you know that you don't want any more children. And we're in the business now of really what we call patient shared or patient directed counseling. We're here to meet patients' needs. And if a patient says she would like to have a permanent method of contraception, we do our best to meet those needs. And we clearly need more accessible and more acceptable ways of doing that. So despite the advance in contraceptive technologies and even LARCs, the unintended pregnancy rate persists as a major public health problem. And in states where recourse in the face of an unintended pregnancy is just no longer available, that decision or choosing wisely with respect to contraception becomes more and more important. Next, please. So where do we go from here? As I think I've really been building up to, there's really no question that, abortion is a contraceptive issue, and it's a very, very personal issue. But this Supreme Court decision, in my view, and in the view of the vast, vast majority of our colleagues, sent us way backwards in time. And we really need to preserve options and expand them. And this recent decision basically means we need to work harder, faster, and better in order to expand these methods, preserving reproductive rights, but making sure that we have more options and not fewer options. Next, please. So, again, this unmet need for women for options in family planning will continue. And as you can see here, although tubal ligation has been performed for over a century, this in-office procedure is a real up-and-coming opportunity. It's a great innovation, and FemBloc may expand these needed options for permanent contraception. And when I talk about unmet need, unmet need is really defined as women who say they want to access a means of contraception but are not using one. And often that's a question of access, or in many cases, a doctor who cannot provide an IUD or an implant, does not know how, or a patient who has contraindications to many of the methods for which we might often advise them to use. And FemBloc doesn't have any of those kinds of contraindications. So again, another opportunity in the marketplace for that approach. Next, please. As a clinician myself who's been doing this a long time, there's no question that this non-cervical and what we call trans-cervical, which means we go through the cervix and not through the abdomen in order to reach the tubes, this has been a long-standing goal. And it's really a win-win for both patients and physicians. As I've mentioned, gynecologists can perform this. We all have ultrasounds in our office. We all have the ability to do procedures. And I think office-based procedures have been a decided trend in gynecology. 10 years ago, we didn't do hysteroscopy in our offices. Now we do it every day. Other procedures such as IUD insertions, assessment of tubal patency, for example, intrauterine insemination of sperm are all things we commonly do in the office now, mainly because we don't want to have to deal with the operating room. So again, FemBloc fills that role very nicely. The office logistics are pretty easy for us. And as Kathy mentioned, and this may be coming up in the next slide, it's very easy for us to make office-based appointments. It's not so easy for us to make operating room appointments or schedule with the operating room. There's a lot of competition for those rooms. And this procedure doesn't take a whole half a day in the office. This procedure would take about the same amount of time as an office hysteroscopy or any of the other common office procedures we do today, such as cervical cancer prevention procedures and so forth. So this really could be a game changer for us, for the clinical world, because of the consistency of care that we can provide to our patients. Next, please. And as we've been making in terms of a point, this really does make it more accessible. It's going to be less costly for us, the physicians, especially because now my day is more centered in the office. I don't have to now take time to run to the operating room, come back. I can make my day more complete in this way. But it's also better for the patient because of the accessibility of an office-based procedure. Reimbursement is always an issue for us. And spending a half a day going to the operating room and back is not cost effective for us. So even if we were reimbursed the exact same amount for an office-based procedure as an operating room-based procedure, we'll take the office-based procedure every time because it just makes much more sense for us. Look, hospital-based bureaucracy, we could go on about that for a while if we really needed to. But at least in my office, I control most of the logistics, and that's really key. The fact that it's approved or will be paid for by the Affordable Care Act also increases the audience for this procedure that we have, whereas reimbursement is not a problem for the patient. Next, please. And I think, as Kathy mentioned earlier in the procedure, I want to just direct your attention to that very first component of office logistics, because we think that one of the things that we've learned from COVID is that we can do a lot by telemedicine and by a video visit. And this first visit where we counsel the patient, determine eligibility and so forth, that is something that we now can almost always do by a televisit. We can even obtain informed consent on a telehealth visit, which reduces the number of the patient needs to take by one. So she can be at home and not have to take off time from work. She could probably do it from work if she wanted, but let's assume she might be at home for the telehealth visit. And no need for childcare, no need for the kinds of things that often prevents patients from making an office visit. So we reduce that by one. We come in for the procedure. The procedure takes maybe an hour or so of the patient's time. Excuse me. And then in 3 months, she would come in for a confirmatory visit, which again is done in the office and takes even less time really than the FemBloc procedure itself. And I have to say that in my experience as both an educator and a clinician, the fact that the patient herself can see the FemView procedure or the confirmatory procedure under ultrasound in our office herself is very validating for the patient. Number one, she gets a view of her own physiology, of her own uterus and tubes. And number two, she can see herself that the tubes are blocked. And that's very reassuring and validating for the patient. Next, please. So again, as I've mentioned, this demand for, in the post-Roe or in the Dobbs world, this demand for permanent contraception will likely increase. I think that FemBloc really could provide women with an ideal choice, and as someone who has their pulse on the, or their finger on the pulse of the contraceptive development world, I don't know of anybody who's working on something similar to this right now. And there's even debate over when conception occurs, IVF restrictions, and this leaves another opportunity for Femasys's FemSeed procedure, because that's related. It's sort of the opposite of the FemView of approach. It's sort of a development related to FemView, which is how we determine the tubes are patent or not. But introducing sperm into the fallopian tubes, which is a relationship, or is a sort of a cousin of intrauterine insemination, that could be more and more of an issue in a world where IVF may be tainted in some states because of the concerns about when conception occurs. So again, looking more globally at the opportunities provided by this broader technology provided by Femasys, I think we have a lot to work with here. Next, please. So I want to thank you for your attention, and I'm happy to answer any questions that you might have about certainly the clinical side of things or the programmatic side. Thank you very much.
Thank you so much, Dr. Blumenthal. So I'm going to just make a few closing remarks, and then we'll turn it over to the Q&A. So, you know, we set out to change things for women. This has not been the easiest of roads. Women's health. I'd like to try to look at the silver lining when we see things happen in the marketplace, and there is a lot more attention, discussion around what are we doing for women, how are we going to expand options, and Femasys is finding ourselves in the fray of those discussions. There's no question that this is a large market and that it's growing, and that women deserve more options, not less, and deserve accessibility. So we definitely see an unmet need. We see one option available in the category right now, and Dr. Blumenthal was very eloquent in speaking of some of the limitations to access that we see. So as we move forward, we have designed this with the patient in mind. We have designed it with the physician in mind. We do have a pivotal trial to complete on the horizon to prove out how efficacious this solution will be. But we believe taking an in-office approach is good for the patient. It's good for the physician. It's safer when we remove the surgical aspects and remove the reliance on an implant long-term. We also think from a patient standpoint, when it can come to them at no cost, it will take away a barrier that will hopefully allow women to make this choice that they should so desire. And then, of course, engage the physician and be able to bring forward to them more procedures in the office where they can treat their patients. So as far as Femasys and how we're preparing for this execution, we have a clear path on the clinical side to FDA approval. There were 2 products that came before us that were not, they utilized hysteroscopy. They fell to the waysides for different reasons, but that pathway is there as far as clinical design and what's going to be required. We also see a clear reimbursement pathway, and we're already walking the walk and have our category 3 codes established and in the books there. And then from a commercial readiness standpoint, we are full GMP at our facility. We are focused. We want to ensure that we bring this forward in the most cost-effective manner, not just here domestically, but globally. And we are also augmenting our sales readiness. We have FemView is a commercial product that Dr. Blumenthal mentioned, where we're looking at open tubes for women that are looking at why they might be struggling to get pregnant or infertile. But we have other products that are coming this year. And this is all before the investment of a sales force, but allows for us to have the commercial sales readiness infrastructure in place to support these products and to work that out in advance. So with that, I'll turn it back over to Tara to host our Q&A.
Thank you, Kathy. At this time, we'll be conducting our question and answer session with our speakers. As a reminder, if you'd like to submit a question, you may do so by using the Q&A text box at the bottom of the webcast player, or by emailing your questions to questions@lifesciadvisors.com. So our first question comes from Emily Bodnar from H.C. Wainwright. Emily, you may go ahead and unmute your line.
Hi, thanks for taking the questions, and thanks for the informative presentation. I have a couple, which either Kathy or the doctor could answer, I guess. How effective does FemBloc need to be in order to get FDA approval and physician usage? Do you think the 6% failure rate that you kind of stated with the surgical procedure kind of applies here as well, or do you think it needs to be more or less effective? And then on the confirmation tests, if the confirmation test comes back and the fallopian tubes were not blocked, what do you recommend for a patient in that situation? Do they kind of get the procedure again, or do you recommend that they take a surgical approach in that case? Thank you.
So I can speak to what we anticipate on the FDA side. When we're looking at presenting performance goal designs to FDA, which is how all of the other previous products, their study designs were crafted. So second mover advantage in that regard. It is all about risk benefit profiles. So what do you have less risk? Do you present the same benefit? And so we do think the backdrop of the effectiveness rate for a surgical approach will be looked upon, will be considered when we develop our performance goal for this study. We do not believe we need to be better than surgical tubal ligation, given the benefits that we bring and the reduction of risk, moving this from surgery to non-surgical, but we would expect to be at least as good as would be our goal. But maybe Dr. Blumenthal, you could comment further. You're on mute.
Unfortunately, the question blanked out a little bit on my end, so I didn't hear all of it. So if you don't mind repeating the part that you might like me to address, I'd be happy to then address it.
I think what Emily asked was, one, effectiveness, and then maybe adoption, if it's as effective as surgical tubal ligation, how would that affect adoption, or does it need to be more
Sure.
or less effective? Yeah.
So first of all, in terms of physicians adopting this, if it's as effective as surgical procedures, there's no reason why we wouldn't adopt it. And if you're trained to do something in residency, which is, again, what we aim to do in this case, then you'll do it in your practice. And in terms of adoption, it makes so much more sense for us to do this in the office than the operating room, that unless there's some reason, which again are very few, why I shouldn't be able to do this in the office, we would likely gravitate towards doing these in the office as opposed to a surgical procedure in the operating room. So I hope that answers that question. And in terms of effectiveness, as Kathy mentioned, I think we need to be as effective as surgical techniques, and that's how studies are usually designed. If we can be better, okay, so much the better. But if we can at least be as effective, and I don't think that should be a problem, especially given some of the recent data, then that's an attainable goal for us.
Great. And her second question was related to the confirmatory test. If a subject comes back and is determined not to be blocked, we have been working with FDA. We have been looking at this for quite some time about being able to offer a second procedure, and that is something we are definitely working on. But as far as what we recommend in the clinical environment, and then I'll turn it over to Dr. Blumenthal for practical, the confirmatory test, I think, is really important for us at this stage, and who knows long term, depending on where we see the placement rates end up, but women are always going to be counseled on alternative methods. So that is something that's par for the course for GYNs to ensure that our patients do not have an unintended pregnancy.
Yeah, thank you. I will say that in counseling a patient about the procedure itself, we always have to say that nothing is 100%. But especially in terms of counseling a patient who, let's say, is coming in for a confirmatory visit, we would broach the topic and say, okay, what if your tubes are not occluded? What if the procedure didn't appear to be effective? What would you like to do? And we can offer patients so-called, workarounds or substitute methods right there and then, because if I'm doing a FemView procedure where I'm assessing the patency or the openness of the tubes, I could say to the patient, and she's watching under the ultrasound, I could say, look, they appear to be open, and maybe we've already discussed that she would take an IUD for the near future. Or I could say I can insert an implant while you're here in my office, again, to give you a longer term contraceptive substitute. So there are some workarounds here, especially since we can make a decision on the day of the confirmatory procedure for your method if that's what the patient wants.
Thank you for the question.
So our next question comes from Catherine Novak from Jones Trading. Catherine, you may go ahead and unmute your line.
Hi, thanks very much for taking my question. My first question is, I was wondering if you can speak a little bit more to the competitive landscape in permanent birth control. We know that tubal ligation is currently the bar to beat, but have you seen any other products in development that are addressing this severe unmet need? And then, sort of looking into the future in the wake of the Dobbs decision, do you foresee potential risks to having ACA-funded permanent birth control? Just kind of wondering on your thoughts on that.
Okay, well, I can start. Dr. Blumenthal, would you like to take
Sure. Well, again, on the clinical landscape right now, and again, as also a contraceptive researcher, there's nothing on the radar right now that's competition to FemBloc. And there also are no surgical approaches being researched right now that are significant improvements on current surgical approaches. So other than just the standard tubals, sort of what we call ligation or just removing the whole tube, there's nothing else new that's coming on that landscape. So that's number one. Number two, with respect to ACA contraceptive methods, I think actually that doubling down of that these kinds of contraceptive options are available, especially because of Dobbs or the Roe versus Wade decision. So I think that to the extent that the federal government can, or that the ACA will survive, and I think it will, then I think there'll be a doubling down of ensuring contraceptive options. That's the very least that we can do.
Got it. That makes sense. And then I had a question on the FemBloc confirmatory test that's sort of being looked at now. Is FemBloc clinical success contingent on the ultrasound confirmatory test? Do you see potentially having to move forward using radiology for confirmation? Should you want to still move the product forward without this test?
Well, again, from a clinical standpoint, we feel, based on what we're finding out about FemBloc, that it's going to be effective. Now, the confirmatory test, I can't force a patient to come back for a confirmatory test. I advise the patient to come back for a confirmatory test, so we both are reassured about the success of the procedure. But all the indications are that FemBloc procedures are effective. Now, that said, we do not want to get involved with radiology if we don't have to, because again, it's hard to schedule a radiology procedure. You have to get involved with the radiologists who do those type of procedures. Actually, patients don't like going to radiology for these kinds of procedures. It's a cold, hard bed in a very unforgiving setting, and radiologists don't know really what they're doing when inserting. I shouldn't say that they don't know what they're doing, but they're not as facile with inserting the necessary instruments into the vagina and cannulating the tubes as we are in the comfort of our office. And so I think that the confirmatory procedure is really best done in the office. We can see what's going on, and what we call the scrubbing bubbles of the FemView procedure are quite visible.
Okay, that's very helpful. Thanks so much.
Thank you.
So our next question comes from Key Nikkei from Chardon. Key, you may go ahead and unmute your line.
Thank you. Following up on that last question, as you get the results of the study, the current study, what's good enough to be able to go forward with the in-office confirmation as opposed to radiology?
So, Kay, it's a small study, 50 patients undergoing both confirmatory tests. So we are looking at concordance with respect to identifying when it doesn't work. So do we see patency, and is that picked up under fluoroscopy as well as it's picked up under sonography? And then on the flip side, if she's determined occluded, is it picked up by both exams? So we're going to be looking at all of those different categories. What does weigh in is what Dr. Blumenthal touched upon. We know in the literature, and this is going to be and has been supplied to FDA, that there's more at stake than just being as good as the radiology exam. We know that women did not come back for their radiology exams. And, we know that there were issues around it. There were issues around misinterpretation for the previous product. So those are things that are real world data that should be considered in the overall. She's much more likely to come back to her GYN that performed the FemBloc treatment than she is to go to a third party by referral. And that will, I hope, weigh into the decision making as well as the data as far as concordance between the two exams when this is being considered by FDA.
And if I may, I'm just going to chime in about radiology procedures as well. They're not necessarily the gold standard that you think they are. They're not unassailable in terms of the interpretation. So with a radiologic procedure, you instill dye into the uterus and then into the tubes. And what the radiologist is seeing is sometimes open to interpretation. And, I can tell you any number of times where a patient has been told, oh yeah, your tubes are completely blocked, you'll never get pregnant. She shows up pregnant 2 months later. I mean, sometimes the radiology procedure is sort of a tubal clean out, you might say, but no, those aren't necessarily unassailable. And also, just like I was mentioning for the CREST study, when we're doing research, we might be dealing with the best radiologist they have in the hospital to be the investigator for our study. When this gets into the open marketplace, if it's a garden variety radiologist, I don't know the level of their expertise in doing what we call hysterosalpingograms or an assessment of tubal patency. So again, this is maybe a silver or even a pewter standard. It's not necessarily a gold standard. That's been my experience over time.
Okay, and post the Supreme Court decision, what kind of inbound interest have you been getting in your trial in FemBloc, and who are the different types of constituents that have reached out to you?
So post the decision, we're drawing to the end of enrollment for the small study. So it's enriched. So we feel that we'll hit that milestone of third quarter. So there has been increased interest, but there's just very few sites because there's very few patients left to be enrolled. As far as other reach, the more media, more interest, the reason we wanted to do this KOL event. So there just been a lot more discussion around and attention to this issue. What do women have available? Is it enough? What's on the horizon? And like I said earlier, silver lining, when I try to look for them, that might be the one for us where there at least is more discussion around it. For a market that's enormous, and women have deserved these things for a long time. So I feel that that's going to continue.
Yeah, and I can chime in. I was just telling Kathy a little while ago before this call that in our own research team, now our component, our role in the initial FemBloc study ended some months ago, so we haven't been recruiting patients for this for a few months, but our research team met yesterday, and we were talking about the various things that are ongoing because of Dobbs. And a couple of my colleagues mentioned, well, we're getting all these requests now for sterilization, some coming from patients from out of state in some cases. They asked me, when are we going to start up FemBloc again? So from the point of view of my own colleagues who are fielding calls from patients, this is a real concern.
Okay, thank you.
Thank you for the question. I'll now turn the call over to Dory Kurowski of LifeSci Advisors to read the remainder of the questions.
Thank you, Tara. This next question that came in is for Dr. Blumenthal. The question is, what is your expectation regarding how receptive you think your colleagues will be to hearing about new options for birth control, permanent or otherwise? And if a Femasys rep is speaking to one of your colleagues on FemView or another Femasys offering and mentions FemBloc studies that are in process, is that going to be something that's going to be in the back of their minds and they'll be following? Or do you think that they need to see FDA approval to get attention?
Well, first of all, there's lots of different ways to spread the word in the clinical community. At some sites around the country in the future, there will be investigational sites where FemBloc is being performed. That creates a cascade effect because residents see these procedures being done. They start to inquire. And what I can tell you without question is that when a resident sees a procedure being done, even if it's not available then, I get calls as soon as that resident finishes training or they go out and practice, starting to ask me, oh, is that thing available yet? When can we do that? How do I get one? And so forth. So that's the kind of cascade effect that even investigational sites have on the marketplace. Second, through the mechanisms such as weekly lectures, grand rounds, etc., physicians are commonly made aware of what's on the horizon. Stay tuned to this channel. Obviously, no one's going to do a procedure until FDA approval is been given, but physicians will express interest to, say, a rep. If they were to call on a physician, say, stay tuned to this channel, I'll let you know when we're ready to roll. And again, the need for the in-service part of this procedure, once we are ready to roll, is pretty minor. I hope that answers that question.
I think it does. Thank you. That was really helpful. We have another question here, I guess for either of you. Can you describe a bit more about the cost savings for FemBloc, and in particular in relation to the LARCs, the long-acting reversible contraceptions, which have been slow to be adopted due to some hurdles in reimbursement? And then also, will the FemView portion of the FemBloc procedure be reimbursed? Do you expect that to be reimbursed?
Oh, Kathy, I'll let you talk about reimbursement.
Okay, so we do anticipate the confirmatory test, the FemView portion of it, to be reimbursed. There are existing codes right now that people are utilizing when they do their FemViews, but we are and have already secured a Category 3 code for when they utilize it to assess for occlusion. The exam can be slightly longer as you're looking for the absence of the travel of these bubbles into the tubes. So time is a little bit more, longer, elongated. The first part of the question, do you want to take it, Dr. Blumenthal? Or do you want
Well, sure. What I can tell you is that, again, relative to anything else, staying in the office is much more cost effective for physicians than going to the operating room. And I think we've established that. With respect to an IUD, which is also an office procedure, IUDs are not cheap. And not all insurances cover all IUDs. So some insurances cover one type of IUD, other insurances cover another type of IUD. They're not required necessarily to cover all IUD types. That said, in my own office, an IUD insertion can be the better part of $1,000. Just because of the fee that I charge to insert it, the visit itself, the IUD itself. So it's not cheap. And then you have maybe I think it's been shown that over the course of the life of an IUD, there are visits for perceived complications, the potential for expulsion of the IUD, and also then reinsertion and removal and reinsertion, if that's how the patient decides to go. That's another expensive visit. So this isn't low cost, but it's effective, but it isn't low cost. So I envision that FemBloc would compare favorably in terms of when you think we're getting 20 years, let's just say, from 30 to 50 or 25 to 45 out of FemBloc compared to a few IUDs in there.
Yeah. It sounds like that definitely adds up. Okay, there's no further questions on my end. So Kathy, I'm going to change it back to you to just provide any closing remarks.
Well, I'd just like to thank anyone who tuned in to listen to this event. It's going to be recorded and made available. And especially thank you to Dr. Blumenthal for agreeing to participate in this very short notice. We thought it was very timely to talk about our product and the work that we're doing in permanent birth control. And so appreciate that he took the time to help educate our audience and to provide his very valuable insight. And thank you to
Pleasure.
the LifeSci team as well.